Excellent. So we've got some folks from Saskatoon, Regina, several people joining us from Alberta today. That's wonderful. Excellent. Hello, Jennifer. Wonderful. So that's exciting to see how many people we have, and we look forward to you joining us in the conversations today. So the second feature I just want to introduce you to, for those of you who are familiar with WebEx, you'll be familiar with the chat function, but if you're new to WebEx, we invite you to pose your questions, comments, and ideas in the chat. So just make sure that that chat function is visible on the right-hand side of your screen, and at any time in the conversation, if you're interested in sharing your reflections, that would be wonderful. And you can also use that chat function to contact me through the HQC WebEx to be able to, if you have any technical difficulties, to be able to share those, and hopefully we'll be able to resolve your issues. So if you'd like to take a moment to practice this function, we'd love for you to put a little greeting into your chat box. And what I'll ask you to do is make sure you're sharing with all attendees so that we can all see what you're sharing. All right, and then just one final note. We invite you to log into your Twitter account and tweet out during this session to share your learnings. You can use our hashtag QIPowerHour, and include our Health Quality Council Twitter handle, HQCSask. And then new to today, you'll also see a couple of additional handles that we've included. You'll see the Healthcare Improvement Scotland's handle, HISQI Connect, as well as Dr. Brian Robson's Twitter handle there as well. So please include all of those handles in your tweets, and you'll be able to share your reflections and your great ideas coming out of today's session. All right, and now I'd like to pass it over to Health Quality Council CEO Gary Tier to welcome our guest speaker for today's session.
Thank you, Lot, and good morning, everyone. It's my pleasure and delight to introduce Dr. Robson. Dr. Robson is the Medical Director of the National Quality Organisation for the National Health Services in Scotland, an organisation called Healthcare Improvement Scotland. He's got a background in general practice, health information technology, quality improvement, and national leadership development. And he keeps himself grounded in the real world by continuing his weekly practice in general medicine in Glasgow. On a more personal note, it was my pleasure to meet Brian in the UK, both in London and Glasgow this past spring. And I can say he's a delightful human being, but also a strong promoter of his city. And so, you know, here in Saskatchewan, we've got a friendly rivalry going on between Regina and Saskatoon. Well, same sort of deal over in Scotland between Glasgow and Edinburgh, and you don't leave Brian's presence without knowing what the #1 city of Scotland is, being Glasgow. So over to you, Brian.
Well, good morning, Gary, and what a great introduction. I'm just checking you can hear me okay? Great.
Yes, we can.
Excellent. So I'm so pleased to be joining our friends from Saskatchewan here, from, as Gary said, Scotland's #1 city. And despite what Ali has said in the chat box, Dundee is not anywhere near #1 city in Scotland. But Dundee is pretty good. Dundee is one of the other cities in Scotland. It's known as Sundee because it gets more sunshine than most cities. And also Fundee, because it's a good fun place to live, study and work. And thanks, Ali, yes, it's a city of discovery, that's right. So listen, thanks very much for the wonderful invitation to share with you a little bit more around what we're doing here in Scotland. And as Gary said, we had opportunity when Gary visited in Scotland to see a lot more. I'm going to share some of that with you. And let's just start by just referencing how far away we are. So we're almost 4,000 miles away from you guys. But, you know, we feel close and closer still as we do more and more work and more sharing together. And we consider events like the Power Hour to be a wonderful opportunity to build relationships, to build collaboration, and to work together. So it's a great pleasure to be with you. For those of you that don't know Scotland, Scotland looks a bit like this from space. These are the various tartans across the country. We have almost 5.4 million population. We spend about £13 billion on health and social care. I'll come back to that and do a bit of a comparison in a moment. We split ourselves up into 14 territorial boards, so that's boards providing services. But the boards range dramatically in size. The small box in the top right-hand element of this map is the Shetland Islands with a population of around 20,000, whereas in the middle of the map we have Glasgow, which is upwards of 1.5 million. So you can tell that those boards, although providing similar functions, they do it in a very different way. And all of those boards are supported by special boards, so kind of doing once for the whole country. So we do once around education, around growing and training our health and care professionals. We have one national services that provide all of our IT systems and all of our information systems. We have one ambulance service for the whole country. We have the Golden Jubilee Foundation, that's a high throughput hospital specialising in orthopaedics, ophthalmology operations and cardiac transplantation. We have Health Scotland, which is a national health promotion and public health organisation. We have the State Hospital, which is one forensic hospital, high security psychiatric forensic hospital. And we have a telephone and online service called NHS24 that provides 24 hours a day access to health and social care by telephone and by web. And we've been moving, and I'll talk more about this during my talk, we've been moving to integration of health and social care for some time now, and in the last 2 years we've now made that legislation, so bringing health care and social care together. And then last, but I would say no means least, is my organisation. This is Healthcare Improvement Scotland. So we're a public body, we're funded by public funding. We have got some autonomy from the government, and I'll come on and say a little bit more about what we do in a moment. But just thinking about the health spend, so this is the OECD data, 2015, so it's a couple of years out of date, but you can see that in terms of our total health spend per percentage of GDP, we're a bit lower than Canada, and maybe we can get into some of that conversation later on. So we have some other differences as well, as you can see even just from the map. The population of Scotland is 5 million, with Canada being 36 million, but even though we consider some parts of Scotland to be very rural, you guys really do take the biscuit on that with significantly dispersed population. And just to bring that to life, Jennifer Graham helped me out with this wonderful slide just to bring it to life. Then we could put the whole of Scotland into Lake Superior. So we love Scotland, and we love some of its rurality. We see the major differences when we look to other nations such as Canada in terms of how you deal with large geographical areas. So my organisation, Healthcare Improvement Scotland, we're the national improvement agency across Scotland. We design and run the Scottish Patient Safety Programme, and I'll tell you a bit more about that in a moment, the national initiative there. We run the iHub, which is where the quality improvement support around health and social care is situated. I'll tell you a bit more about that in a moment as well. We also run the Scottish Health Council, so we have offices across the country where local members of the public can be engaging with how the health service is both run and any issues that they have with the health service. We also inspect the hospitals and hospices across the country, so as well as an improvement role and a public voice role, we have a significant role in inspection. We also inspect the death certification so to check to ensure the accuracy of death certificates. So for those of you that are using the chat function, how would you like to put some guesses in around the proportion of death certificates that we find to have an error in them? So the proportion, the percentage of death certificates that have an error. And while you're typing those into the chat box, I'll tell you about the rest of the functions of Healthcare Improvement Scotland. We also regulate and license all of the private and independent healthcare in the country. So the private sector in Scotland in terms of healthcare is about 3%, so small, but we regulate and license all of that. And then from the evidence side, we provide the functions of NICE. You may be familiar with NICE in England, and we do health technology assessments around all new medicines to recommend or not their use in Scotland. And we have a 20-year history of bringing together the professional medical colleges around signed guidelines to produce guidelines around clinical matters. We've been doing that for 20 years. And the new kid on the health technology block is the Scottish Health Technologies Group, where we do health technology assessments around non-medicines technologies. Now that can be anything from asking the question, are single rooms in hospitals safer and have a health economic basis in terms of benefits for patients, all the way through to, is a new device worth using in terms of both cost and clinical benefits. So you can see we're a bit of a mixed bag in terms of organizational parts, but we consider ourselves to be integrated. We carry out all these functions with the purpose of improvement. Now I see, just looking back through the chat box, thanks very much Glenda, thanks Christina, and thanks to yourself Jocelyn. So 25%, 10%, 12% and 17%. Well, nope, you're not even close. In the first year, the percentage of death certificates that had an error was a startling 53%. So 53% of death certificates in the first year had an error. 10% of those required a reissue of the death certificate. So we only found that out by introducing the Death Certification Review Service, and that's now already dropped we're going into our third year, it's already dropped to 34% through education and feeding back information to the doctors in the local sites. And I just see your suggestion there, Ali, around 70%. So you were getting close on our 53–54%. So as an organisation, we do a lot of things. And just before I go to Winston Churchill, my organisation has just launched its new strategy just in the last couple of weeks, and we'll make sure that that's sent out, thanks Jennifer, to our community. And we focused in that as an organisation to say that all these parts are for one purpose, and that purpose is to improve care. So the rest of my talk is going to be describing a little bit about how Scotland has done over the past 10 years. But in the words of Winston Churchill, we firmly believe this is not the end, not even the beginning of the end, but perhaps it's the end of the beginning. And we genuinely believe that, and we know that folks like yourselves in Canada are feeling similar as well. And this little cartoon is just to remind us that sometimes quality improvement can feel really messy. Here then Israelite is saying, man, I ain't so sure about this. That looks pretty muddy to me. And certainly those involved in quality improvement know how difficult it is both to support others and for people to actually undertake improvement and have confidence, because it is muddy, it is difficult. So when I look back over the last 10 years, I'm going to use this framework, and I commend it to you. It's created by the Institute for Healthcare Improvement. The main author, Steve Svensson, was the head of medical development at Mayo Clinic. And it's basically a study of high-impact leadership. And colleagues from Canada, Ross Baker and others, have done similar things over the years to study what are the core components of successful organizations. In Steve's model, he talks about 6 areas. I'm going to use this lens to look back over our work in Scotland. So let's start with one of his first areas. In the first area, he talks about it's critically important to create vision and build will. And in Scotland, we have had huge support from the clinical community from the get-go. And this is my old boss. This is Sir Graham Teasdale. Sir Graham Teasdale is famous, nothing short of famous. He and Brian Jeanette invented the Glasgow Coma Scale. Many on the call will know the Glasgow Coma Scale for an assessment of the conscious level of people. It's used all over the world. So Graham was the chairman of my organisation before we moved into Healthcare Improvement Scotland, and he was an accomplished academic, a global name in neurosurgery, and as I say, a real advocate for data and academic study, hence the Glasgow Coma Scale. However, Graham came up with this great phrase that we've had 5 decades of clinical audit, 10 years of clinical governance, and the future will focus on patient safety and reducing harm. His point being that the clinical community and the academic community had to really understand how reliability and other methods, other scientific methods, would really be the future for making healthcare safer. We also had huge support from this lady. This is, of course, Nicola Sturgeon, who is, of course, now our First Minister, but at the time, 10 years ago, was the Cabinet Secretary for Health. Excuse me. Nicola was a huge supporter of the early days of the Patient Safety Programme. She made it her business to understand the data we're talking about. She made it her business to go out and into the wards and into the clinics to see how things were working. And she worked very closely with our then Chief Executive, Derek Feely, and our Clinical Director, Jason Leach, to make sure that she was understanding what was happening in patient safety. And that political support was critical. And out of that political support came a national policy on quality in 2010. And that national policy was driven around the IOM 6 dimensions, and in particular, safe care, effective care, and person-centred care. Now, that document is now 7 years old. It's difficult to believe it's been that long. It contains a driver diagram. Who would have believed that a national government policy document would have contained a driver diagram and an aim statement, just in the way that quality improvers would start with any quality improvement activity. So it was astounding looking back to think that we had that, but it came out of that political will. And that clinical and political will has been carried right through to our current Chief Medical Officer, Catherine Calderwood, who's in the bottom left of this image. Catherine is our Chief Medical Officer, and she produced this amazing report last year. I think, Jennifer, you're going to just send a little link to that. But this was her Chief Medical Officer report for the country. And, of course, the Chief Medical Officer talks about the health of the nation. The report talks about demographic changes, scientific changes, government policy around health. But that was all there, but it was in the appendix. The realistic medicine, the main message to doctors was these 6 questions. Can we change our style to shared decision making? Can we build a more personalised approach to care? Can we consider how we reduce harm and waste? Can we study and reduce unnecessary variation? Can we manage risk better with patients? And then that final bottom right is, for me, it blows my socks off every time I look at it. The Chief Medical Officer is saying, can we become improvers and innovators? So the Chief Medical Officer is continuing that will building that Graham Teasdale started some 10 years ago. And it's wonderful to have that leadership on an ongoing basis. In order to build will and bring people with us, we brought a lot of people together. And for years, perhaps for 6 or 7 of those last 10 years, we brought together 800 or 900 people for 2 days from all over the country to talk about things like ventilator-associated pneumonias or medicines reconciliation or leadership walkarounds or how do you use data for improvement. And it was important to convene the co-producers, to bring those together that were trying to improve care. And the other thing that we've done successfully looking back is to celebrate success. Now, I've met a fair number of Canadians, and I've been over to Canada. I've had the privilege to be over there just recently in June at the Atlantic Learning Exchange. So there's many Canadians that are a bit like Scots. We're proud of what we do, but we don't really celebrate it as much as we could. And it's really broken the mould a bit here in Scotland to have Scottish Health Awards, to put doctors and nurses and physios and carers up there in the limelight to accept an accolade. But we've broken out of our usual comfort zone of being more modest, and we've celebrated success. That's been one of the key elements for building will. Now, moving through Steve's framework, looking back, developing capability. 10 years ago, there were very few people that could describe quality improvement. Very few people had studied it. Very few people could say what it was, or could point to it, could discuss it with others. And this is the Frank Davidoff and Paul Batalden famous quote, that everyone in healthcare really has two jobs when they come to work every day: to do their work and to improve it. Now, if you study that and you read the paper, it's a great paper to read. It's really making the point that we've built a whole profession or numbers of professions based on subject matter knowledge. Let's be an expert in our field. And of course, this is Deming's lenses of quality improvement. So of course you have to be a subject matter expert. Graham Teasdale was one of the world's top neurosurgeons. But you had to do something more to actually improve things. You had to look through the other of Deming's lenses. You had to look at the importance of systems. What's going on around you? What's happening? How does your system work? What are you dependent on? How are you dependent on teams? You had to look at variation. You had to look at data. You had to study data, and you had to understand its trend over time, and you had to understand the underpinnings of studying variation. And epistemology, we had to study knowledge. How do you study and understand knowledge? How does knowledge get translated? How do you simplify knowledge? And of course, one of the biggest impactful elements of not just Deming's work, but all change agents' work is psychology, the psychology of change. You could be the smartest kid in the block, but if you don't understand what makes other people tick, and you don't understand how teams work, you're not going to improve anything. So you bring those two things together and you get improvement. And that's really what we've been studying and trying to create capacity and capability about here in Scotland. And we've worked very closely with support from the Health Foundation, a UK-based charity, and the Institute for Healthcare Improvement in Cambridge, Massachusetts, to help us really understand that. They introduced us to new tools, many of which you on the Power Hour will be very familiar with now, but I can tell you 10 years ago we were not. But looking at those new tools, studying other industries, that has been part of our capacity and capability building. And of course we know, as you do, that it's not just about the tools. So that if you took just the surgical checklist, and Atul Gawande's wonderful, the Checklist Manifesto, he summarizes it in there to say, using the checklist requires, in his case, doctors to embrace different values from the ones we've had. Humility, discipline, and teamwork. So it's behind those tools, understanding the deep meaning of the tools and how they actually work. And in Scotland, I'm delighted to say we have the NHS Education Scotland, who have developed a whole series of programs, some of which I'm displaying here on the slide. And Laura Allison, who leads that work, is an inspirational leader in terms of building capacity and capability in quality improvement. And we're now building that capacity across health, across social care, and across all elements of government. And it's quite an amazing feat looking back, and all credit to Education Scotland and to Laura. Just one of the examples is the Quality and Safety Fellows. We, in fact, have our first Canadian Quality and Safety Fellow this year from Nova Scotia joining us. But this is a fellowship program. It's in its 10th year. We now have, as you can see, 222 safety fellows. That's the breakdown of the professional groupings. You can see at the bottom how it breaks down in terms of the countries that are now joining to learn together. And as part of that, I have the great privilege every year to interview the UK and Irish intake. And this is just a wonderful quote that I got from a couple of years ago. It was from a district nurse. It's a nurse that works in the community. And when asked at the end of the interview, you know, why do you want to do this? She said this: I've realized that there's a greater world out there. I want to be a credible clinician, improving care. This is my professional future. Now, she didn't even know anything about Deming back then. She knows about him now. But if you look at her words, if you get the passion across that table, you can see why clinicians really need to have other tools in their toolbox. And I'm delighted to say that she went on to become an outstanding quality and safety fellow. And one of the examples, of course, of building capacity and capability is the Power Hour. And we have our equivalent over here, which is QI Connect. And QI Connect, this is the lineup of speakers that we've had this year. We have, as you do, as Jocelyn introduced today, you record your talks. We had a great talk yesterday from Tom Marshburn, who's an astronaut, qualified doctor and astronaut from NASA. These are all available, and you're welcome to use them at any time. And please, please, please look out for Sally Magnuson's talk. Jennifer and I have just prepared with Sally this afternoon. It's going to be an amazing talk on the 21st of November, and it's going to be about dementia and how dementia touched her life with her mother and a subsequent death of her mother, but also what she went on to create, which is a charity around music for people with dementia and the impact of music on their life. And the Playlist for Life is the charity. So please join us for Sally's talk. But this is a big question for us here in Scotland. So we've got all these resources, but what are we doing with them? Are we actually using them? So what we've really been trying to do over the past 2 or 3 years in particular is make sure that all of those fellows get in a position, supported by their chief executives and their medical and nursing and pharmacy leaders, to make sure that they're actually used for the new skills. And those new skills have been delivering results. So the third area of Steve's framework is looking at results. And this goes to Deming's famous quote around, in God we trust, all others bring data. So we need data. So part of our change theory here in Scotland are these simple messages. We need a clear and stretch goal, a measurable goal. We need a method of how to do it. And we need to do it by small tests of change, not big bang. So that's the underpinnings of our change theory. And there's Deming there reminding us data, data, data. And these are just some of the data. I'm going to skip through these pretty quickly, but yes, we study the hospital standardized mortality. We know that it's a controversial measure, but we've seen a significant reduction over the past 10 years. We're now measuring this differently, so I've stopped this particular measure at October to December 2015. We have data everywhere. We have data up in the walls. In our hospitals, at every ICU, every ward, we now have data talking about meaningful data in terms of outcomes. This happens to be an ICU unit in NHS Fife, where the data is up there around the days between days since the last ventilator-associated pneumonia, since the last fall, since the last pressure ulcer, etc., etc. But that's a very public display of data. And when we study it in more detail, we can see the clear correlation between an increased reliability of processes around ventilator-associated pneumonia. If you do these 5 things reliably every time, look what happens to the pneumonias. We eradicate ventilator-associated pneumonia. Now, 10 years ago, you would have been laughed out of town if you suggested that you could eradicate ventilator-associated pneumonia. And the local figures here from Glasgow. Significant reductions. Pressure ulcers dropping. We're seeing falls. Falls are pretty tricky. I'd love to get into conversation with Power Hour folks around how you reduce falls. We're just in the early stages of that. We're now seeing national data around sepsis. So this is not data collected at the wards or at the sites. This is national data coming through on coded data. So you're seeing here, a 21% reduction in deaths associated with sepsis. Quite astounding. As a result of a number of initiatives, that's for sure, not one thing, but one of them one of the core elements is a sepsis collaborative around the sepsis 6. And folks on the call may be familiar with the 6 things that you need to do within the first hour of anyone being diagnosed or being suspected as having sepsis. And it seems like 6 things. How difficult can it be to do 6 things? But folks on the call will know that actually, as our study showed, this was a Mary Dixon-Wood's study that her team from Sheffield did, it's not just 6 things. It's actually around 60 things that need to be done. So for instance, just if one of those things is starting fluids, there are about 6 or 7 different steps to start the fluids. And only when you understand the complexity of on-the-ground change do you actually say, you know what, this is much trickier than just 6 things. And some on the call may be familiar in terms of our data and the data that we're doing. We've been studying now for 3 years the work of Charles Vincent under the Health Foundation. We're trying to get much deeper into understanding how you measure and monitor safety. And our colleague here, Jo Thompson, has been instrumental in leading this charge over the last 3 years, and she's linked in with colleagues in Canada, and you're now studying whether having a different framework that looks beyond past harm into reliability, safety in the moment, anticipation, and how you integrate all that learning. So big shout out to Jo Thompson, and just to say Jo leaves on maternity leave today, so it's a big shout out to Jo. We'll miss you and we're looking forward to hearing how you're getting on. And so the Charles Vincent framework for us has allowed us to really deeply consider how we move from looking for an absence of harm to the presence of safety. And we may get into that conversation on the call as well. And as we go into the final stages of Steve's framework, we're talking about our safety program started in the intensive care unit because that's where the worldwide evidence was 10 years ago. But we are now taking our safety activities out into the community. So maternity and children's, we've been doing the maternity and children's quality safety program now for some 5 years. Mental health safety program we've now been doing for some 4.5 years. Primary care safety program out in general practice, out in community pharmacy, now in dentistry in the community. So we're taking a lot of the learning out and much, much wider than the intensive care, much wider than the hospital setting. And it is not plug and play, we're absolutely sure about that. But there's a lot of things that you can apply reliably elsewhere. And our direction of travel here in Scotland is to move from the big hospitals to the GPs, to the local community home, care homes, and of course to people in their own home. And I would commend this resource to you. It's our iHub resource. Ruth Glasborough, Ruth Glasborough, my colleague, is the Director of Improvement in the iHub. And yep, just there, Glenda, if you look at that, thanks for that wee prompt. If you look at that wee URL link there, just iHub, and you'll find many of our resources there telling you exactly what we're doing in each of those settings, and we're always delighted to collaborate. So if you see something on there you're interested in, click on one of the links and we'll start to make connections. And as Steve closed his framework, he looked at 2 areas that are critical. One of them is you can do all that, but it's for the birds unless you consider the culture of an organization. So Dr. House is now famous all over the world, and usually in an audience I would ask, well, who would want Dr. House in their team? But I can imagine that you're sitting there wondering, yeah, he's a pretty clever guy, he's an amazing diagnostician. I might want that, but there's no way that I want his behaviors on my team. And I'm just going to share with you a little example of what I saw, and this is what it feels like here in Scotland. Elaine is the charge nurse. She's on the left-hand side here with the white bandana hat on. And this is her running the surgical brief for the neurosurgeons in the Western in Edinburgh. And that circle goes all the way around. There's probably 30 people in the room, 2 neurosurgical teams preparing for their Friday patients. Each list is probably 2, 3 or 4 people, no more than that, because it's complex surgery. And they're doing a brief on each of those patients with the whole team present. And one of the most amazing things for me as I listened with them that morning was that the lady third from the left, after one of the surgeons had closed his summary of what he was going to do that day on that particular case, that lady said, "Excuse me, you haven't told us which kit you're going to use." And the surgeon didn't bat an eye. He said, "You're right, I didn't. I'm going to use, I may use kit A or I may use kit B." And this lady, this nurse says, "Well, I understand that, but if you tell us which one, then we'll prepare that one kit. I think that's the rules that we have here." And he said, "No, you're quite right. I'm going to go with kit A." And I thought, well, that was quite a nice interaction, that. But what happened at the end was interesting. I went up to ask Elaine, you know, is that interaction that just happened, how was that for you? She said it was brilliant. She said that was our brand new scrub nurse. She'd only just started a couple of weeks earlier, asking the senior professor which kit he was going to use. And there was no abreaction, there was no storming out, there was no how dare you. It was very much flat hierarchy, easy to ask questions, and as Elaine said, you want the questions asked then, and for that nature or that ability to follow through into theatre as well. And the end of the story for me was, as we were leaving, going to look at another part of the hospital, the surgeon stopped in the corridor and said to me, he said, "I now consider the safety brief to be every bit as important to the safety of our patients as to what I do as a surgeon during the operation. I don't know why theatre teams are allowed not to do a morning brief. I wouldn't operate without it." And he closed by saying, "That was not just for you, that is a core part of our work here." So impressive, and a real insight into the culture that we're trying to develop here. And those safety briefings are happening reliably now across the country, which is wonderful. This is a different type of briefing. This is again to the culture. How do we make sure that we've got whole hospitals thinking about the needs of people, patients? And this is a hospital huddle. You'll be doing these in Saskatchewan and elsewhere. But this is the Sick Kids, or the biggest hospital, the biggest children's hospital in Scotland at the time. And Jen Rogers, who's running this huddle. And this is just some of her data. So they come together in the morning and they'll discuss all the critically ill patients. They'll discuss facilities issues. They'll discuss any discharge issues, etc., etc., etc. And they'll do it for all of the hospital in under 20 minutes. And this is just one of the elements of impact of that, a significant drop in any form of delay in discharging children from the paediatric intensive care to the step-down ward. And they know that that has been associated with the introduction of this huddle. Previously, children would be kept in the PICU if there was issues to do with further downstream discharges, or the rooms weren't available, or there were issues around staffing. They're now sorting all those things out reliably and regularly at the huddle. It's a great example. And this is John Burns, the chap second from the right. He's the Chief Executive of NHS Ayrshire and Arran, and he's just one of the very many executives, and indeed non-executives, that now regularly do walkarounds across Scotland. And some of the cultural elements are coming through in our safety climate survey tools that we're now using. And in the mental health safety program, they're taking views in those safety climate survey tools that we can make freely available to you in Canada, where they're asking questions about whether patients are and feel safe, and whether staff feel and are safe. So it's really critical core questions that are now being asked. And I'm going to close now by just finishing on the final and the central point of the whole framework, the point of all of our work, in fact. Steve highlighted the importance of people, or persons, and community at the centre. This is a quick story. Don Berwick, many of you will be familiar with Don, the previous president of the Institute for Healthcare Improvement. When Don was asked by President Obama to go down and run the HHS for President Obama, he of course said yes, but then he reached out to his nearest friends and family and asked for advice on how he would keep the patient or the person right at the centre of his work. And this is one way that his brother, Bob, who was a retired teacher, he gave him this. Well, this isn't this is a replica of it. This is one that sits on my desk now. But it sat on Don's desk all the time that he worked for President Obama, and he would point to this for every single paper that came across his desk in every meeting. He would say, I hear what you're saying, I understand what you're asking for, but tell me, how will it help the patient? So Don, through his work, was continually putting the patient at the centre of major policy and investment decisions. And our Chief Executive here in Scotland of the whole NHS is Paul Gray. And Paul came up with a wonderful quote, the patient experience will define the future of the NHS in Scotland. And we know through Paul's leadership, through Jason Leach's leadership and others, that this is absolutely fundamentally part of the Scottish journey. So in that run through, Gary, I've taken you through Steve's framework. I've taken a probably stylized and slightly cleaned up version of the last 10 years. But I'm delighted to have had the opportunity to share, and I look forward to your questions.
Wonderful. Thank you, Dr. Robson. Very inspiring talk, and it's really neat to see kind of some of the stories of your journey. We have just a few questions on the chat. Gary had just leaned over and commented to me how much he loves to see the data being presented as run charts and control charts, so bravo for that. I was curious, and I posed this in the chat, but I'm wondering if you could speak a little bit about how you've included patients and family members into your various quality improvement efforts.
Yeah, thanks, Jocelyn, and thanks, Gary. Yeah, it is great. It's wonderful to see run charts and control charts. And I can tell you, 10 years ago, you could probably have found, 5 or 10 people that would even have known what they are. In terms of how we engage the people and the public, we're still in the early part of this journey on this. So we have surveys, of course, of people and their experience of care. We have a wonderful service called Care Opinion. And Care Opinion is, it's the, they don't like us saying this, but it's the TripAdvisor for health and social care. But basically it's as easy as TripAdvisor, and the people who use services and their relatives and family and carers can go on and they can pass comment. And the vast majority of the comments that they pass are very positive. You can find out about my practice here in Glasgow as a general practitioner. You can find out the local hospital, etc. So that experience is coming through from the ground up from an organisation called Care Opinion. However, we're now building in through the Scottish Health Council, or part of our organisation, and other parts of the system, we're now building in measures around patient-reported outcome measures and patient-reported experience measures. And one of the groups that we're working with to explore this is the ICHOM group, ICHOM, and I'm just going to blank entirely on there, but it's the International Collaboration for Health Outcome Measures for People. So we're building those measures in. But early stages, Jocelyn.
Great. Yes, it's always a challenge and something that we can work toward improving in terms of how we do our work as well. I see Jennifer's posed a question, and I suspect that this question has probably been extended broadly to everyone who's on the call currently to respond in the chat and provide their thoughts as well. But she mentions the challenge that it really is for folks that are working at the point of care to be released from their day-to-day duties to support sort of those higher level QI efforts. And if you have advice that for everyone that's listening in, that you strategies that you found to be successful to support staff to be involved, we would love to hear. But I don't know, Brian, if you want to speak to that question at all as well.
Yeah, very much so. And again, it's back to that Paul Batalda and Frank Davidoff quote. If we're serious about quality improvement, then we have to make two parts to everyone's job. So do your job and improve your job. Not one part, do your job, and then find the time at another time to actually improve it. So we've been serious here, and we've been deliberate, and we're now, all of the boards in Scotland, all the board members and the chief executives, the executive teams, are now very familiar with the people in their organisations who are now trained in quality improvement. All of those quality improvement fellows, we expect them to be used to improve quality. So there's no point in putting a cardiologist through the training program, a year's training program, only to go back and just do cardiology. Sure, that he or she can go back and improve cardiology, or they can do cardiology for some of the time and improve the system or help others to improve. So we've been deliberate. We've got a board-on-board development program to try and build the expectation in board members and executive teams. And importantly, we've built the skills in amongst the folks themselves. So there's really a movement, if you like, at board level, at the most senior level, and enablement at the front line that we're trying to build up here. And we're really serious about it. 10 years ago, we didn't even know what to be serious about.
Yeah, that's such a great point, and I love the term that you use, that it's a movement, and of course that doesn't happen overnight, but we get sort of closer in that journey, I suppose, as we move forward. There's a group of staff here at Health Quality Council that are watching this webinar from another space in our office, and they've posted a question on the chat, just to, I guess, looking for some thoughts on how you would suggest closing the gap between knowledge and the actual application of QI, because certainly we find that we have a number of different training opportunities for folks in our province, and it's really getting people more comfortable to be able to use the tools and apply them in their own work. So any thoughts you have and advice you have for us, we would love to hear.
Yeah, so it's a great question, actually. I guess the first thing, somewhat flippantly, that comes to mind is the Nike, just do it. There is no way to improve things better than just to try and improve something. Improve something, anything. Put it into practice in your everyday life. Put it into practice in your work. Here in Healthcare Improvement Scotland, we do all sorts of quippy things to try and get our administration staff, our finance staff to use PDSAs. So there is something about actually doing it. Also, make it simple. Don't make it complex. So many of the training programs will take you into the background to funnel plots or run charts or control charts. You've got to get through that. You've got to make it as simple as possible to the widest audience. So, our training program in measurement is very different now from where we started 7 or 8 years ago. More technical then, much more practical and simple now. And a part of our organisation, of course, as you'll have seen at the beginning of my talk, is dedicated to knowledge, building guidelines, doing health technology assessments. And that group is now, the health service researchers are now energized by, not that they weren't energized before, but even more energized to try and simplify quality improvement. So they are working to do economic evaluations, outcome evaluations, using health research tools around our improvement activity. We really should know whether actually it is patient's experience is a positive one if you are trying to improve medicine safety, etc. So applying knowledge in a different way. And again, Deming used a complex phrase. Of course he did. He is a very complex man. And he used epistemology, a term that most people don't know what it means. I'd never heard of it before a few years ago. But how do you study knowledge in a way that you can actually apply knowledge? So simplification is the key, Jocelyn, and I think there's nothing better than putting quality improvement into practice all the time. Do it in primary schools with feeding plants water, Coca-Cola, and drought. Just put it into practice.
That's a great comment, and I feel like I could learn something maybe from my kids too in the way that they test and trial some of their projects with school. I think Gary has a question here for you as well.
Thanks a lot for that, Brian. That was a wonderful presentation, great overview of all the fantastic work you guys. I'm amazed how much ground you guys have covered in 10 years, and many parallels with our journey here. So just like you, we're also moving in the direction of trying to shift healthcare away from, the big acute hospitals, and there's a big initiative going on here in the province around what we call connected care, where we're trying to really work more in developing team-based care in the community in order to be able to pull people from hospital and keep people out of hospital. And you mentioned in your safety work that you're moving into safety initiatives in mental health and primary care and so on. I wonder if there's 2 or 3 things that jump out in your mind as lessons learned or things that are different when you go to do safety in those environments that would be good for our folks here to hear about.
Thanks very much, Gary. Yes, there are some things that are different, but I can tell you the vast majority are in common. So let me just give you a couple of examples of things that are actually work really well, and then touch on an area which is are different, if you like. So one of the things that we're doing just now is we're working with our sister organisation, the Care Inspectorate, that looks at social care, inspects and helps social care to improve and care homes to improve. And what we've done there is we're just working just now, just with 2 or 3 care homes here in Scotland, to introduce or to test the use of SBAR. So the situation background assessment and recommendations, and using SBAR in care homes in out-of-hours settings. So there's something that you might not have thought too much about, or we hadn't thought too much about. But how do you structure the conversation if the care home needs an out-of-hours doctor or out-of-hours assessment? And using SBAR has been amazing for them. It's really had the same sort of transformation that it had when we used it in wards and hospitals. It makes it much more structured, much more easy to have a conversation, much more clear about what you're asking. So the use of SBAR is something which has actually been in common across those areas. And the whole business of culture, one of the things that we're doing in the community pharmacies and community dentistry are around using culture survey tools. And hey presto, isn't it amazing? When you ask a team, a mixed team, professional, administration, different professions, when you ask a mixed team in a survey how safe do they think their organisation is, you get huge variation. When you break it down and ask about leadership, study of adverse events, preparedness for safety, etc., the variation is even higher. So using safety climate survey tools in maternity units between obstetricians and midwives, in general medical practice between GPs and practice nurses and administration staff and practice managers, wherever you go, if you do a safety climate survey tool, you'll find that variation. And although we've got tools and they're on our website, it doesn't much matter what tool you use. It's about the conversation when you start to look at the variation. And there are some things that are really, really different. When you go into people's homes and start to work in people's homes, and you start to look at new technologies you could use in the people's homes, that becomes really tricky, because in general we don't use all that much technology in our hospital to here in Scotland to support us in that. A lot of it's still very people dependent, whereas in hospitals, if we're looking at digital in people's homes, if you're looking at digital interventions, that will bring us some real challenge and difficulties.
Thanks, Brian. I'm seeing another question here from Ali as well. Bearing in mind the principle of doing your job and improvement, which we love that quote as well here in Saskatchewan. She's asked, what is the biggest challenge that you feel you are facing still in improving healthcare in Scotland? And Ali, this was a question that I had as well, so would love to hear, Brian, your thoughts on kind of where you're heading next, I guess, in your journey.
Well, typical of a Dundee girl, always getting the last word in. Nice to hear from you again, Ali. So I think the biggest challenge for us is not thinking that we've got it done. So one of the risks, one of the challenges for us is that the only reason that we can be confident around ventilator-associated pneumonias is because we are deliberate and continue to monitor the reliability of care. And if we turn our attention from that wonderful beginnings of reliable health care and start to turn our attention away from it, those things will start to suffer. So the biggest challenge is, how do you go to health and social care, how do you go to people's homes at the same time as sustaining the gains? How do you hold the gains? And that is a lot to do with capacity and capability building, it's a lot to do with leadership building, it's a lot to do with working collaboratively internationally, in the way that we're doing on this call, and the way that the Power Hour really reaches out to bring people together.
What a wonderful way to end. Thank you so much, Brian. And I want to extend a thanks not just to you, but also to the colleagues that you've brought with you who are very active on the chat today. Thank you, Jennifer, for sharing some great resources with our community. And your story was really inspiring. And as Gary mentioned, Brian, very much lots of parallels in some ways to some of the things that are happening here in the province, but also some great learnings for us as well. So thank you so much.
You are very, very welcome.
All right, and just as we are approaching our last few seconds of the call today, I just want to take this opportunity to remind everyone about our next QI Power Hour that's coming up for November, and it's very fitting that we will be welcoming Stacey Lally, who is Head of Delivery of the Q Community with the Health Foundation in London, England. I believe we might have seen a couple of references to Q on some of your earlier slides, Brian. Stacey is going to describe how healthcare improvers in the UK are connecting with and learning from each other through their co-designed Q community. And we are very much looking forward to that call being a jump off from some of the conversations that we started on this call. So just as a final closing, we would like to invite you to provide your feedback on today's session. As you log out of your WebEx, you will see that there will be a survey launched to respond to, and we appreciate your feedback and hope you will give us your comments and suggestions so that we can continue to improve our future QI Power Hours. So with that, I will wish you a wonderful day and a great weekend, and we will look forward to connecting again in November.